Hello and welcome. We just have a few announcements before we get started. Thank you for joining us for the 2023 NHIA Annual Conference. We ask that all attendees, even those that don't require a CE, please complete the overall conference evaluation. Your feedback helps NHIA develop programs that meet your needs and improve the event year after year. You have 45 days to complete the evaluation and claim your CE from the live sessions, but you can earn CE credit on demand for 1 year following the event and enjoy the sessions you couldn't attend while here in DC. The evaluation code to complete the session survey will be provided on the last slide and at the end of the session. Don't need CE? Please take 1 minute to give us your feedback on the session by using the QR code at the end of the presentation or the kiosk just outside the room. During the Q&A portion of the session, and to make sure that our recording of the educational session is complete for on-demand viewing, we ask that you please do use the microphone for all questions. This will ensure that our recording equipment picks up all questions for the on-demand content. Now, introducing our speaker, Shannon Stoffel, Home Infusion Field Nurse for Fairview Home Infusion. A little bit about Shannon. She's one of Fairview Home Infusion's oncology nurses. She has over 14 years of oncology experience, including bone and marrow transplant, outpatient hematology, and oncology, and home infusion nursing. Shannon is one of 15 current oncology nurses with Fairview Home Infusion team. She has been drawn to oncology care and this unique patient population since becoming an RM. She is excited, inspired, and passionate about the improvement in quality of life of offering chemotherapy and other therapies in the home that provides patients and their families. Thank you.
Good morning. I just need the clicker because I'm not standing up here. Well, thank you so much for joining me this morning. I know it's been a fun but long week. I don't know about you, but my brain's pretty full, so take what you get. Like I said, I'm not going to stand on the podium, so I'd like to keep it informal. If you have a question, I don't know about you, but I get to the end, and I'm like, what was I going to ask? Or I write it down, and then I don't remember why I was asking it. So feel free to interrupt. As Chris mentioned, please use the microphone so that those who are viewing this later can hear the questions. Objectives are to talk about the drug approval process for home infusion with chemotherapy administration, identify the criteria for appropriate patient referrals, summarize our safety processes for administering chemo in the home, and to describe our dual sign-off process for appropriate chemotherapy documentation. This is just a quick snapshot about Fairview Home Infusion, just to give you an idea of what we're managing. We are part of an integrated health system, mHealth Fairview. We were discussing this recently. It's either 9 or 10 hospitals. There's been some confusion with some changes, but 60 clinics and 34,000 employees. Included in those clinics is 9 infusion centers that have anywhere from 6 to like 40 infusion chairs. So a pretty extensive infusion center capacity. Some quick stats about Fairview Home Infusion itself. We average a monthly census of about 2,400 patients. We have about 100 in-home nursing visits Monday through Friday that is shared between about 28 to 30 nurses. On the weekends, we also staff with a significantly reduced census of about 7 to 9 nurses. And we also have an infusion suite that is a home infusion suite, so it's not like the infusion center, is still considered part of the home infusion arena. So patients who have a lot of kids and don't want us to come to their home and would prefer to be in the infusion suite. And then there are some therapies we only offer in that setting as well that we haven't deemed appropriate for the home. Included in those numbers on the weekend, because this is an immuno-oncology talk, we have about 2 to 3 of those nurses on any given weekend are some of our chemotherapy competent nurses. To give a little background on our home immunotherapy and chemotherapy program, began managing chemo in the home in late 2019. So this did precede COVID, although you'll see as we continue that advanced pretty significantly when the pandemic hit. The initial interest and conversations were stemmed from provider requests. So there were situations where the patient needed therapy. One of the protocols that we were using was Vidasa. The infusion centers weren't open for 7 days in a row, and there were patients that the providers didn't feel it would be appropriate to do a 2-day break and then continue the final 2 days of their 7-day protocol after that break. So this was one of the things that was requested of home infusion, knowing that we were a 24/7 operation. The services were originally limited, other than that, Vidasa, to continuous chemotherapy infusions. So those included like our fluorouracil, our doxorubicin, ifosfamide with Mesna, Blincyto, and dacarbazine. They were either serviced with an elastomeric home pump or with an electronic infusion pump, depending on what the insurance carrier required or what was required for proper administration. The continuous infusions were some of the easier things for us to manage. The discontinuation, the visit times, those things were really predictable. We knew that the infusion was to be discontinued 46 hours later, or if we were doing bag changes, we knew that it was going to be after 4 days. So it was easy for us to kind of coordinate those things. It's important to point out all of our disconnect appointments can be completed by any of the nurses on our infusion team. However, those bag changes, any other more complex care needs for those oncology patients were carried out by our chemotherapy nurses. One of the other things that came out with this, because again, we weren't doing this when home infusion started, was they added an initial core competency to everybody's orientation so that they were appropriately trained in safe handling of chemo waste for those disconnect appointments. Starting in the middle of 2020, so a few months into COVID, we really expanded our program to assist patients who were not solely on a continuous infusion. We also included immunotherapy and biotherapy at that time, and those visits could be on any chemotherapy regimen schedule, so whether it was monthly or every 2 weeks, weekly, daily, whatever that need might be. The providers were increasingly aware of the option, knowing that we had started doing those disconnect patients, and so the wheels were kind of turning, right? The providers are like, oh, well, if you can do that, can you do this? The oncology service line was also invested from a leadership perspective to have this transition because of the strains that they were experiencing due to the pandemic. So if a lot of the infusion centers were deemed to not accommodate social distancing due to their chair spacing, and so some of the infusion centers had to eliminate chairs. They took down curtains because we weren't sure how we were cleaning them, kind of all of the things that came along with COVID. So the infusion centers were experiencing a significant strain. They had nurses going out who were ill, so their staffing was reduced. Patients didn't want to go to the infusion center because they didn't want to be exposed to those pathogens. So this kind of gave us an opportunity to really catapult the program. In the early 2021, so about a year into the pandemic, the chemotherapy at home program expanded even further when they hired an oncology-specific supervisor. So she was a supervisor from one of the infusion centers, and so she brought all of that experience to the home setting. After the supervisor was hired, they also added that for any of the nurses on the team who weren't certified in oncology, that they would complete the ONS course, the fundamentals of chemotherapy, just to kind of give them some additional education. As the patients, right, like we're going to disconnect the chemo, and so the chemo's infused, but it doesn't mean that the patients don't have questions about how to manage their care. So patients would be like, I'm feeling really good, is that gonna stay? And they were kind of like, I don't know, maybe, like, I'm glad you're feeling well now. And we don't really know, right? But as an oncology nurse, we can say, Well, most people start to feel a little rough, 3 to 4 days after the chemotherapy as it's taking its toll, and kind of, depending on the therapy, of course, but kind of give them that additional education. So it gave them an additional support in their knowledge to help the patients better. On our team currently, we have 15 chemotherapy competent. Oh, whoever that was, thank you. So we have 15 currently employed chemotherapy competent RNs. Most of them, I couldn't find out every single one of them, but most of them are also oncology certified. So with ONCC, so not just the ONS courses that you can do. There's a fundamentals course and then a longer course that's, I think, 15 hours. So these are like nurses who have done oncology certification. They all came to us with prior oncology experience, most of them coming from infusion centers. Excuse me. And I should say, I was looking at this and I was like, well, 15 sounds good, but how many nurses do you have at all? So I've talked with my boss and she presented earlier, but we have about 50 FTE nurses and then another 20 to 25 casual nurses. So it's a significant chunk of our team, almost 20% of the team are chemotherapy competent nurses who can do all of our chemotherapy visits, not just the disconnects. We cover a very large portion of the state of Minnesota, and we've provided services to hundreds of patients. The program also features 24/7 pharmacist and nursing support. So going back to the education piece, all of the nurses rotate that triage aspect. And so a patient who had chemotherapy or was infusing could call the triage nurse at any point. And so it was important to give them some additional education so that they could better support our patients after hours. This is our list of currently approved drugs. You can see it's relatively extensive. Our most widely utilized protocols at this time are fluorouracil, Blincyto, ifosfamide, Avastin, or Mvasi, Vidasa, and Velcade. All of the therapies on this list have been administered in the home by our team since the initiation of the program. And even though we don't have patients on all of these right now, we have had 0 safety events related to administration in the home. And that's a big deal for us because it's kind of scary to administer chemo in the home. We currently have about 275 patients who are on our disconnect or bag change service, and about another 25 to 30 patients who are receiving some of our other more complex therapies, again, as often as daily, depending on the protocol. As I mentioned, those pump DC patients can still be seen by any member of the team. They get shared equally among all the team members in terms of who's assigning them or who's receiving them to case manage, as all of those patients still get a case manager. But a lot of our disconnect patients do land on the weekend. That's been something that's also helped the infusion center, because historically, if they were gonna do like a 2-day pump, they can't hook up a patient on a Thursday or Friday because the pump disconnect lands on a Saturday or Sunday and they're not open. So it also gave them increased flexibility for utilizing their chair space to be able to do those 48-hour pumps on a Thursday or Friday, knowing that the patient could still get their disconnect at the appropriate time. We do have some criteria. I don't find this list to be overwhelmingly obnoxious, which is obviously helpful, but there are some really important pieces. First, the patient needs to reside in our service area, which currently includes 11 counties, mostly in the metro of Minnesota. We do see some patients in western Wisconsin. We have a subset of nurses, I think it's about 8, who carry a Wisconsin license as well. So as long as we're able to coordinate a case manager for those patients, depending on the complexity of their care, right? If it's a pump disconnect every 3 weeks, not a big deal. If we're talking about daily Vidasa, we need to make sure that we've got adequate nurses who can go to Wisconsin to take care of that patient. We do also have a select number of patients who are managed by our regional agencies. So the patient has historically been receiving home care services from one of our partners, and then they also need chemotherapy disconnects. So we will include them, we'll allow the regional agency to do that disconnect for the patient so they don't need an additional service. And our education team provides that training to the regional agency so they're able to do that. Next, the patient needs to have already tolerated the therapy. We're not doing any first dose chemotherapy in the home, right? That sounds like a terrible idea, no matter how you spin it. So we do require a full cycle of their ordered therapy in a controlled center. So it can be either inpatient or in an infusion center. And then insurance coverage, right? Yay, insurance. We've already heard in lots of talks this week that insurance coverage is still a problem in the home infusion arena. Chemotherapy is no different. So we do need to verify that the patient has insurance coverage for the service. It's definitely our largest barrier to providing that care in the home. And then one of the other things that I recently experienced with one of my patients that we're able to do is we are able, as the pharmacy, to work with the pharmaceutical companies if they have a compassionate use program or a free drug program. We are able to partner with them and utilize that through our pharmacy services as well, which for the oncology population can be very impactful depending on what their scenario is. So who could benefit? Wow, who couldn't benefit? If I needed to do it, I'd certainly like to be at home. So the reality is it can be really any patient or a patient with any diagnosis. It's more about what is their ordered therapy, right? We don't say, oh, well, we don't do breast cancer, we don't do colon cancer, or whatever. It's all about what is their ordered therapy, and is it approved for us to give it in the home based on our standards. Some of the patients that have benefited the most from this are patients who have trouble getting to their appointments. Maybe they don't have reliable transportation. Maybe they have a caregiver that they need. We have patients with mental or physical disabilities who just function better in their space, or it takes an extraneous effort to get them out and into an infusion center. We also do have patients who just prefer it, and I think this is something that we've seen pick up since COVID as well. They don't like the busy infusion center. They don't want the exposure to pathogens, and it's a more intimate environment. One of the things that I've heard a patient talk about just recently is that her preference for therapy in the home really had nothing to do with anything except that she didn't want to burden her employer with being at work or with being gone from work. And while she had a laptop, she couldn't be very efficient because she has dual screens and all kinds of safety or like firewall things in her home. She works for a bank. So she can't just exactly be doing that work anywhere. And so instead of going to the infusion center where she would spend, 6 hours getting her labs done, seeing her doctor, waiting for the labs to result, waiting for the pharmacy to compound, having the nurse do the infusion, she's like, I'm so much more efficient when I'm in my home. I have my own equipment. While you're mixing the drug, I can be working. So it was just a convenience factor for her and just less intrusion on her life. So how do we do it? Referral process. Most of our patients are identified by an infusion center nurse, an RN care coordinator, a provider, advanced practitioner, as someone who might benefit. So this really, in this current atmosphere, really relies on the healthcare team recognizing that there's a problem or that they might benefit. So there are instances where I think we're probably missing some patients who really would benefit from that in the current atmosphere, but we'll take it one step at a time. So they send us a referral. The referral is sent either through Epic InBasket. They can call us, they can email us. We're really open to making this the easiest process we can for our referring providers. We do have, as I mentioned at the beginning, we are part of an integrated health system. So we do have 100% full access to our Epic system, which does increase our efficiency and make things a lot easier because we can see the referrals coming in real time. It just makes us a lot easier for everybody involved. The other thing I'll mention just about patients is, as our footprint has increased in the community, right, we have 275 patients who are currently receiving like even just disconnect services from us. But that's this moment, like literally that's the number from last week. But we've been doing this now for 3 years. So patients are hearing about it from other patients and they're like, oh, you needed chemo and you got it at home? Like, how do I do that? Right? It doesn't work for everybody because again, it's gotta be an approved therapy, but there is more chatter about it. Like people are hearing about it because our footprint is increasing that way. After we receive the referral, we have oncology care coordinators. These are nurses, primarily 2, who review the case. So they pull them up in Epic or they look at the orders we've received and ensure they meet those criteria to receive the therapy in the home, right? So they're in our area, they've got insurance coverage, those sorts of things. After they review that case, they send the information to our intake department. And I feel like this is just a really important part of our process, is that we haven't even, the provider may have mentioned it, they may have sent us the referral without even telling the patient they were doing it, to be like, I just wanna see. I feel like in the healthcare environment, providers are thankfully increasingly aware of the amount of times we get told no by insurance companies right now, or that we have to go through really extensive steps to get things approved with prior authorizations. And so I think they're becoming more and more aware of, they've been like, yeah, you can get your chemo in the home. And they tell them, and then we go through all the steps and the insurance company's like, no, you can't. So I think it's been awesome that we do this, right? So the intake department, before anyone from home infusion has even talked to this patient, has run their benefits, knows that they have coverage, and if a prior authorization was needed, they have obtained it. So this really helps kind of take away that letdown when we tell somebody that we can't do it. Again, if the provider didn't give us that grace, you know, we're kind of stuck, but I feel like they're really becoming better about that. Once the benefits are concerned, our oncology navigator takes the patient kind of into their bucket and reaches out to that provider to say, hey, thanks for the referral. We've checked into it. Patient is covered for these services in the home. Are you still wanting to move forward with that option? The oncology navigator is a single position at this time, is a non-nurse, but they're a member of the home infusion team, so they're an employee of home infusion. And this person's worked really hard. I really like right now that it's a single person. Obviously, as we hopefully can help more patients, a single person probably won't be realistic, but he's really established great relationships with those providers. When you look at the list of approved therapies, right, it kind of lends itself to certain groups of patients that we see more often than not. You know, your colon cancer patients who are getting 5FU, those providers are like, yeah, do the disconnect at home, that's great, no big deal. We've got a really great relationship with one of our providers who sees sarcoma patients, and they're one of our larger users of our more extensive oncology care. And those patients are really complex, and it's really helpful for them. But this navigator has really established those relationships, and so when he reaches out, they're like, oh yeah, I've talked with you. You know, this last time it went really well, yeah, I'd like to do it again, that kind of thing. And then once the provider has agreed, then we contact the patient, notify them that the option does exist. How do they think about it? Education is a really big part of that notification. So while doing things at home is nice, there are things that need to be coordinated so that the patient understands their responsibilities in the process. So they need to be home for the delivery, for instance. You know, we're not just gonna leave your chemotherapy on the doorstep and hope that the porch thieves don't find it interesting, right? Because they're not gonna bring it back if they take it. We also need to make sure that the patients realize that once they have established with home infusion, they can't bounce back and forth. And that's not to say that they can't go back to the infusion center later, but they can't have this cycle in the home, the next cycle back at the infusion center, the next 2 in the home. That's more of a prior authorization thing, but it's also a coordination of care. It's just really messy to be doing that back and forth, leaves an opportunity for a patient to fall between the cracks if the clinic wasn't expecting them back, and creates a lot of unnecessary work for the team. So it is kind of an understanding, like, if we're gonna do this, like, we're gonna keep doing it until there's a reason not to. And like I said, if we need to, the patient can transition back. So I think the time this happens most often is the unfortunate situation of progression, and they need to change the plan. Well, the new plan isn't approved for treatment in the home, so back to the infusion center we go. But that's, I think, the only one I'm aware of. Otherwise, we had one recently that she didn't like being home for the deliveries. It was just more coordination than she was hoping for. And we don't want this to be a burden. The goal is to make it easier, so we helped her get back. The drug approval process. So when we started, I mentioned that it was really those continuous infusions and like Vidasa and Velcade. Those were those really early drugs. But how did we get to the 20 that are on there? So the drug approval process is something that they've given a lot of thought on so that we make sure we're doing our due diligence and not doing something that's unsafe for the sake of being convenient. So when we get a request for a drug that's not on that approved list, the medication needs to be reviewed by the Fairview Home Infusion Clinical Safety Committee. This is a committee of, I believe, 14 members and is multidisciplinary. So we have members from nursing, pharmacy, we have our quality team members, our education team members, and of course, representation from leadership. So it's really on them to take a really deep dive into whatever we're talking about and make sure that it's safe, not just to give in the home, but how do we get it there? How do we store it? How do we reconstitute it? Those types of things. The drug information is distributed to all of the members on the team. They take a chance to review it. Some of the things I just mentioned are the things that they really focus on, but I'll show you on the next slide what that form actually looks like. But so again, they look at stability. What's the route of administration? Are there black box warnings? Are there safety issues? How do we store it? What kind of reactions do we expect when we administer this type of therapy? And how are we going to make sure that the nurse in the home is prepared to manage that reaction should it happen? So this is the form they use. On the left side, it's the medication, who was looking at it, like when was it approved by the FDA. So you can see there's a lot of information on the left. On the right is essentially the action steps after they've said, okay, these are the things. So in the upper right-hand corner, you can see they list, is it in the infusion suite or is it in the home? And I was like, oh, I've never seen this form before. Chris, tell me more about that. And we do have some therapies, non-oncology therapies, that we do only offer in the infusion suite. At this time, all of the drugs that are on the list I showed at the beginning are approved in the suite or in the home. So right now, none of our oncology drugs need to be administered in our infusion suite. So they've been deemed safe enough for the nurse to be by themselves. Then they have the meeting, talk about any of those reviews. And then on the bottom, it talks about how are we going to dispense it? Do we need a new template? They do supply templates, which are really helpful. So the coordinators, when they are seeing that a patient's going to be on a fluorouracil pump, what do we need to send to the home so that the nurse is prepared to take care of that patient when they arrive? So they have these set templates like fluorouracil. These are the 10 supplies you need to send with that delivery. And then if there's any follow-up from the safety committee that's needed following. Like I mentioned, the only first dose therapies have been administered in the suite. And after that, all of the subsequent infusions have been moved to the home. And I think that just really reiterates that these patients aren't trying to move from one infusion center to the other. They're really trying to do it in the home. And so far, we've been able to accommodate that, which as an oncology nurse is really awesome. As Chris mentioned, I started in blood and marrow transplant was my first job, which was inpatient, right? So like, if you would have told me when I started that job, they're like, we're gonna be doing chemo in the home, I would have been like, okay, that sounds great, like what? After I did that, I moved into the outpatient infusion and oncology hematology side of things. And so I was like, yeah, this is really cool. Like patients aren't in the hospital, they're able to get their therapy, maybe it's only an hour every 3 weeks, whatever it might be, but I was like, this is great. And then someone was like, you should check out home infusion. And I was like, but I don't want to lose chemo. They're like, you don't have to. And I was like, I am listening, tell me more. So it just feels really full circle to me, right? To be like, we have come so far, and I've only been a nurse for 15 years, and there are really cool things happening. For those of you who are at the session on Monday, Dr. Jane was asked about innovation in healthcare. And I really appreciated his comment. Like, he said, obviously, like, we need innovation, but he said, sometimes it's not really like innovation that we need. And I'm like, I don't feel like chemo in the home is really innovation. Like, we're just doing something that makes sense, and we're challenging the status quo. And so I just really liked that he commented on that, because I'm super excited about what we've been doing and what I know we're gonna be doing. And they're, like, the oncology team is constantly looking at, like, what's the next therapy we can do? Like, how can we help the next patient population? So I'm excited to see what they come up with. Maybe we'll be back in a few years and tell you more. After they vote to approve it, the members vote, are we gonna approve this? Are we gonna disapprove this? Are there any reason why? If we approve it, we add it to the list. Makes sense. If we don't approve it, we do go back to the clinic. We explain to the provider, we're not able to accommodate this therapy in the home for X, Y, and Z reasons. And the patient obviously remains in that setting. At this time, to date, we've only disapproved one request, and it was for alemtuzumab or Campath. We just didn't feel like we could do that one. If it's all right with you guys, I'm just gonna take a quick sip of water. It's a lot of talking. I'm also getting over like a little, whatever, so. All right. Everybody still with me? Any questions? Doing all right? Yeah, can you use the microphone, or I'll summarize it, either way.
What do you do with if someone's on the multi-drug regimen? Two drugs might be on your list, but the other two aren't, or they're spaced out, or how do you do that?
Yeah, great question. So it really depends on the protocol. I would say globally, with the list of drugs that we have, if it's mix and match like that, they've really stayed in the infusion center. I don't think we've come up with a great way to do that. I will say there have been some exceptions to that with patients who might be receiving like Velcade in combination with like Dara or something, that we've been able to change that and still help the patient on those off cycles. But I wouldn't say that that's globally been something we've come up with a good idea. So if you have an answer, I'd love to hear it. So again, after the patient's been accepted, the patient really stays in that oncology care navigator or oncology care coordinator and the navigator's bucket. So it's essentially a team of 3 people who are really good at doing really complicated things for a lot of patients at once. They manage for all of those patients the scheduling. And because these patients are being seen in the home setting, but the care team still wants to know when the patient is scheduled for infusion, we're actually duplicating those appointments in our scheduling. So for home infusion, we use an electronic software on the internet. And so the patient's scheduled there, obviously, so I know that I need to go see the patient. But then they're also scheduled in Epic, like any other appointment that the patient would have within the health system. So the provider can see, okay, yep, Jane is scheduled for therapy on Tuesday, and we actually even update the time. So they default everything to 6 a.m. so that it doesn't interfere with the patient's schedule. And then we go in and change it to whatever time we've arranged as the nurse, what time we've arranged to infuse that patient. For a select number of our providers, they ask us to also schedule the lab appointment in Epic. Most of our providers are not requiring that, but some of them do want to know, like, what day are you collecting the labs and what day are you infusing? So we will schedule that appointment in Epic as well for them. But again, those lab appointments are scheduled in our home infusion scheduling software. The navigator and coordinator will also obtain all of those orders. Luckily, most of the time they're in Epic. The providers are good about using Beacon in their treatment plans, and so we're able to pull those orders right out of Epic, so it makes that process pretty slick, being that we have full access to the Epic system. The care coordinator and navigator will also assign the case managers, and with our oncology population, specifically those who are getting the more complex therapies, we schedule with a co-case manager to really just kind of help manage the complexity that these patients can present. We do a lot of our case managing by region. We're a bigger team, we've got 15 oncology nurses, and luckily they're all spaced pretty well. And so we tend to partner with the same people, so the nurses figure out how we communicate with each other, and it's just easier for the patient, right? It's fine that we have 15 nurses, but it's also nice for them to see the same couple of faces, especially because they're welcoming us into their home. The orders also, they'll assist with provider communication, the navigators and the coordinator. So whether that's Epic in Basket, a phone call, those types of things, the method of communication really just depends on the urgency of the need. So when we're through all of that, right, like the drug is approved, we've got the referral, we've done all the work, we're ready to do it, what do we actually do? So for our patients who require labs, which come out of their treatment plan, we typically draw the labs 24 to 48 hours prior to that infusion date. The time really depends on the frequency of their treatment. So if we're seeing a patient who's got therapy every 3 or 4 weeks, we'll usually draw those labs 2 days ahead of time. If the therapy is on a tighter timeline, every week or every 2 weeks, we really reserve those lab appointments for just the day before, so we make sure we're not artificially failing the patient on their parameters because we drew the labs too soon. If a patient has an in-clinic appointment, I mentioned earlier, we don't let the patient bounce back and forth for their treatment, but if the patient's going into the clinic to see their provider, we do allow them to have the labs drawn there. That's not something that we need off. And again, we're just trying to make it easy for them. Like, we don't need to be like, okay, what time's your clinic appointment? Okay, we're gonna come at 2. We don't need to increase the complexity, so we leave it so that they can have those labs drawn in the clinic. For patients on established treatment plans, the appointment prior to their treatment might be virtual. We've seen a lot more of this as the pandemic kind of pushed us into those virtual visits. And for a lot of our patients who have been on their therapy for a while, so Keytruda is one of the drugs we give at home, right? We're kind of giving it indefinitely in a lot of situations. The provider doesn't feel like they need to see the patient in person, and so they're doing their appointment virtually. So patient gets labs done at home, they see their provider virtually, and then they get their chemo at home. It's very slick. And again, as our capabilities with virtual visits have increased, I feel like that's just gonna continue to be part of our world. If the lab parameters are met, so again, our treatment plans within our health system are very specific. They order the labs, but then they also list the parameters. If platelets are less than 75,000, if Billy is greater than 1.0, creatinine is greater than 1.8, whatever it might be, it tells us exactly what's appropriate and what we can proceed with, and when we need to notify the provider. Some of the providers are more comfortable with this process. Again, they've used our services a little bit more than others, and so they will, they'll sign their treatment plan ahead of time, right? They're like, we trust that you're gonna check the lab parameters. If they're no good, you're gonna let us know. Some of the other providers who are maybe newer to the system or newer to doing therapy at home, they will wait until those labs that we drew a day or 2 ahead of time have resulted before they will sign the treatment plan. We don't care which way it is, but we will not dispense anything until we know that the therapy plan or the treatment plan has been signed. And that's one of the ways that we make sure, obviously, that we're meeting the requirement that all chemotherapy orders are written. We don't ever do a verbal for chemo. So this way, we know that we're always covered. We haven't dispensed a thing, and we don't even start it until we know that the treatment plan has been signed. One thing I will add with this too, the delivery is set up for the drugs. So we do send everything currently via courier. And that is done either way. Some of our drugs we compound in the pharmacy, because of the requirements for safer constitution. And others, like our biologics, we will compound ourselves in the home. So the day of treatment, the nurse will make a visit to the home. We do a complete head-to-toe assessment. We obtain vital signs, determine what vascular laxatives we're going to use. Most of our patients have ports, but we do have some who are using peripheral IVs because their therapy is spaced out enough. They do a full med reconciliation process, and they do it all in Epic, and that's so that the proprietor can see all of the information that we've done. The drug is prepared and we do a double check. So just like in an infusion center, we still have 2 independent nurses verifying that dose. They're checking for the weight, the height, does the dose match what we said it should, those types of things. They do that separately before they initiate a call, and we'll talk a little bit more about that. We have really capitalized upon the explosion of Microsoft Teams, and it has worked very well for us. Yeah, so we should do a screen share with the second nurse, and I'll talk a little bit more about that. The drug's administered, and we do dual charting, right? No nurse wants to hear the word dual charting. You're like, please, no, I don't want to do that. Why? So we do our home infusion charting in CPR Plus, at least for now. And then we also do extensive charting in Epic. So when the patient is seen there, or when the documentation is done, it includes documentation on the MAR. The vital signs are all in Epic. That head-to-toe assessment is in Epic, and everything is there. The charting from this visit is identical to what is done in the infusion center. So other than the provider looking at the department, they will see the exact same information that they would expect to see as if the patient had been infused in the infusion center. One of the things I will say, and I appreciate whoever's idea this was, with our dual charting, through collaboration with the billing team, we were able to eliminate as much charting out of CPR as possible. And now the only charting that's done in there is what's required for the billing team. So they have really scaled that back, and we're very appreciative of that. So it's essentially the shortest version of our standard home infusion visit note, which is very helpful. So the dual sign-off process. This was a big deal, right? You know, we're like, hey, they're like, can we do chemo in the home? We're like, absolutely. They're like, how are you gonna do it? Don't know, thanks for asking. We're gonna figure it out. So here we are. We developed a method to release it through Epic, right? We all have access, so that was easy. How are we gonna co-sign it? Real time. So you don't have to back time it. Awesome. So we did this because obviously we require a cosign for any chemotherapy or immunotherapy or biologic therapy that's used for a cancer treatment. We used our best practices to figure this out, right? So cosign is a best practice. I'd also like to note all of the other best practices we use, right? We still use PPE. We're still using closed system transfer devices. We're still using the same hazardous waste bulk versus trace. We're using all of those things in the home as well. So while we're very safely administering the therapy, we're also documenting it, we're also very safely administering it. This also helps keep our patients out of the higher cost settings of care. Some of the patients have shared with us that it saves them money because they're not having that facility fee from being in a hospital-based infusion center, which at least in the Twin Cities, all of our infusion centers are hospital-based. All right, so the nurse in the office. So this is one of those oncology care navigators, or oncology care coordinators. She's in the office. We have primarily 2. They verify the ordered dose and the current patient weight. They make sure that the BSA has been updated appropriately. Verify the ordered dose with the BSA. Are we dispensing what we ordered? If they don't match, we assure they're within plus or minus 10%. That is our system policy for chemotherapy administration. Very standard with best practice. The nurse in the home, or the nurse in the office also verifies the drug name, the volume, how we're administering it, the expiration date, if it was compounded in the infusion pharmacy, and the rate and how we're administering it, whether it's via gravity or an infusion pump. the in-home RN is completing those same exact steps. So once the nurse in the home and the nurse in the infusion pharmacy office has verified this, the nurse in the home initiates a Microsoft Teams video call from our laptop. All of us have them. We have like the Air Wi-Fi, so we're always able to connect to internet. We don't need to rely on a patient's Wi-Fi connection. And while we're doing this, the in-office nurse will request control. So if people haven't done this in Teams, they came up with this really creepy way for someone who's not even by you to control your computer. It's actually pretty sweet. So the nurse in the home will allow that control once they get the request. So you have to allow it so you know you're doing it, but it says, hey, so-and-so would like to request control. Sure, that sounds great, please do so. The nurse in the home has at this point pulled up Epic, and we have the medication administration record available. I will say the one thing we don't do at this point is barcode. Patient doesn't have a wristband, we don't have a scanner, don't know if that's coming or what, but one thing we don't do. The patient is with us, states their name and date of birth. Both of us are looking at the same screen, verify it is in fact them. Goodness gracious, I hope so if we've gotten this far. The nurse in the home, so if we had to reconstitute the product, the nurse in the home will save the vials and any number of syringes that were needed to complete that. So we do, I think Dosage actually does this, like they take pictures. I'm not a pharmacist or a tech or compounding, whatever, but we'll show them the vial. So we'll say, this is the vial, it was 400 milligrams and 30 mils. Here's my 30 mil syringe. Here's the 4.4 mils out of the 100 milligram syringe, and we show them the vials and the syringe itself. So we get really good at figuring out where camera angles are on those computers. So once the nurse has verified in the office that what we've pulled up is in fact what we're to give, we do the sign off. So the nurse who's logged into Epic, right, it doesn't make you put your password in again because you're already there. So the second nurse accepts, and because they now have the control of the computer, they enter their password, their username and password. So we've accomplished the dual sign-off. They've seen the drug, the patient, they were able to do the patient verification with the patient standing there, and they've been able to see exactly what we're administering. Once all the documentation is complete, they can see everything. Like I said, the documentation at this point fully mimics that of what is done in the infusion center. Same visit type, it's the same navigator fields. We use the same dot phrase for what we went through. The only difference, again, is that department of administration. Just a few comments from some of the nurses who have been administering therapies. This was a patient who had gait disturbances and just some mental developmental issues. And so it was just kind of a chore. You know, the different setting of care could be cumbersome to the day and could really ruin things later. GBMs, we do see a fair amount of in our home setting. And so, you know, they kind of have some natural disease progression issues that being in the home can help support. This was a particularly fond patient. I was in the infusion center when this patient was treated. He had muscular dystrophy and leukemia. Talk about winning the lottery, right? He was getting 5 days of Dacogen on top of Venclexta, which was oral in the home. But his mom was trying to work. His brother also had developmental issues. And so it was just a torture chamber for her to try and get this patient to the infusion center every day. He was also still needing to come in for transfusions. And so in between his treatment, so yay, we got through 5 days of treatment, but now next week you need to come back for platelets, and 2 days later you need to come back for blood. Those are things we can't do, so relieving these 5 days of treatment was a really big deal for this family. We have osteosarcoma patients. Again, this is one of our more complex regimens we do pretty frequently. Lots of these patients end up with amputations. This was a patient. He would spend 6 hours driving, waiting, appointment, labs, pharmacy compounding, infusion. Took him 6 hours. We did it in the home. We got it down to 2. It's a big time saver, especially when you might not win your battle. I would certainly rather spend 2 hours of my day than 6 hours of my day receiving treatment. We had a patient who lived in a group home, and the group home didn't have staff to get the patient consistently to his appointments. Kind of a problem when you're trying to beat a disease. Again, 5 days in a row, so we were able to send this patient into the home. As far as I am concerned, this, like I said, has just been a really awesome thing to kind of stumble into. I feel like it was placed here for a reason in my life, and I really thank you for coming and hearing more about what we're doing, because I'm really passionate about it. So thank you. Does anybody have any questions? And again, please use the microphone if you do.
Hi, thanks. This has been an absolutely awesome presentation.
Thank you.
Kudos to you and your staff. You're doing amazing work.
Thank you.
I'm sure we've all learned a ton. I have 2 questions, one quick one. So your oncology nurses that are oncology competent, is that all that they do, or do they do other
Great
infusions?
question. No. So as I mentioned, we have the disconnect patients, but really any nurse can do those. And then we have about 25 to 30 patients who are getting those more complex therapies right now. That number waxes and wanes, but on our current census right now. So no, we see all kinds of other patients. So tomorrow, I have a pick pull, CLC and labs. I do have a chemo disconnect, but we do see all other types of visits, yes.
Thanks. And then on a little bit more global question, as you kind of launched doing this, doing these therapies in the home, did you have any kind of pushback or, kind of political issues within your organization for the concern of taking business from your HODs?
Yeah, so I would definitely say I wasn't here for the actual initiation. I would also like to just take a moment. Holly Mahawal is my supervisor, and she prepared this presentation for me. But I would say, having been on the infusion side, I did hear of some of those things. I think we have a pretty good established relationship, being part of the same system. We're still part of the same organization, but at the end of the day, the dollars are still coming to Fairview, right? Of course, everyone wants to meet their budget and those types of things. So I think there was I think there were some providers who were definitely more early adopters, and those providers are still really consistently referring to us for patients because they've seen it and seen the impact it can have. But there's definitely some. Yeah, it was not like yeah, that sounds great. Take our revenue. Please do. Yeah.
Yeah, great presentation. I really appreciate it. I also have 2 questions. My first question is from a pharmacy perspective. I'm a pharmacist, and we have launched a similar program, but our biggest hiccup is if the insurance is going to pay for these expensive drugs, and a lot of times we're finding that they don't necessarily require pre-auth, but we don't know if they're going to pay for it in the home, and you won't know until you do it. So the risk of a $10,000 or $20,000 drug in the home is a huge risk. Do you have any advice for that?
Being way more on the nursing side, I don't, but I'd be happy to talk with our team because we do have a really great intake and billing department, and I think they would probably have some suggestions. I don't personally have that answer. I apologize.
No, that's okay. Thank you. And then my last question is more related to nursing. If you have waste in the home, there's not really clear guidance about waste of oncology products except for pills, right? So if you have bulk waste, somebody started an infusion, had an infusion reaction, what do you do with that waste? And
So it may not be the most cost-effective version of doing this, but we currently actually send a bulk hazardous waste bucket to the home. So we don't care, we don't actually discriminate if it was like a disconnect and we know it's empty, or should somebody have a reaction and we need to stop, or we lost access or whatever. We use the bulk dispensing or the bulk waste bins in the home. They send them with us so that they can be brought back in those containers. They're literally like a mini version of the same ones we use in the infusion centers and in the pharmacy.
Perfect. Thank you.
Yeah, you're welcome.
Hi. When you're starting I know you said you weren't at the ground level on this, but if you were to start something like this, where do you start? Do you start with the home infusion company getting the nurses ready, or do you work with oncologists first, or who comes first? Because you got to go to the oncologist saying that you're preparing. I mean, yeah.
I mean, I think you would really need to establish the nursing force first, because to say that you're going to accept referrals and then be like, well, I don't have a nurse for that. So I would definitely suggest the nursing part of it first. And hopefully you would have nurses who are comfortable not having all of their work be oncology based, right? Not a single one of the nurses who are in home infusion of those 15, not a single one of us only sees chemotherapy patients. So we are home infusion clinicians who also have a subspecialty of oncology. But I think it would be a big burden to your referral source to say that you were ready and then to not have those nurses. I think you could talk to oncology. This is just my personal opinion. I didn't mention it. I did lead that infusion center for 8 years, so have a little bit of that part of it too. But I think talking to the oncologist to be like, hey, if we did this, would it be something you would be interested in, to kind of just get that buy-in before you invest in oncology training. But I feel like they kind of come together, but I think you'd be really kind of holding yourself back by not having the nurses first.
Hi, thank you
Yeah,
for your presentation. My question is, so if your nurses are fully in Epic, they're releasing the order in Beacon, they're administering on the, are they administering on the MAR? Or?
Yes.
So then, I guess, is the order, after it's been released, doesn't it drop into pharmacist verification queue to have the dual verification before a nurse can administer it? How do you guys go around that? Or are your medical center oncology pharmacists kind of looped into this, and are they verifying the order before you
So
have
our oncology pharmacists, I may have, I think that was in there, but I don't remember talking about it. Our oncology pharmacist is also doing a double check. So we have pharmacists in the home infusion pharmacy that
Epic.
are oncology, and they also do a check before we even dispense it. So they've done that work ahead of time. My suspicion, just knowing how Epic can work, is my suspicion is the way we're getting around that double verification is that you can set a lot of those settings by department, and because we're infusing this product from the home infusion department, my suspicion is it's dropping
straight to
them.
okay. Yeah, okay,
I could find out for sure. If
Yeah.
you're interested, I'd be happy to get your card and talk with them. But I know you can turn certain things like that off by department.
Okay.
And so having it go that way, but we can certainly find out.
That's
a great build question.
No, that sounds good. My background is I come from oncology.
Okay.
So I'm more used to the ambulatory infusion center.
Yeah.
And I'm new to home infusion. So this is my first NHIA.
Me too.
It's cool. My second question is for your chemo competent nurses.
Yes.
So you have chemo certified nurses, and then you have chemo competent nurses. What's your criteria for your institution deeming them chemo competent?
Yeah, so all of the nurses who are currently in our chemo competent bucket, I think all of them might be OCN certified. We were double checking. But like I said, if it's not, it's really close. But the Fairview system has requirements for administering chemotherapy within the system. And so it includes either, we had a recent combination, so some of them are attending a chemotherapy, it's 3 days of chemotherapy training and doing all of that. And then some of them are doing the ONS, Oncology Immuno-Oncology course, so the 15 hours every 2 years. And so they maintain that. But almost all of them are OCN certified from their prior work.
We're using the ONS, the fundamentals of
Yeah.
immunotherapy and oncology as the foundation.
Right.
And then the workflows are offered by our
Yeah.
ONS Foundations, IT workflow, our Beacon workflow, and then Shannon and Holly mentoring.
Any other questions? I think we still, my watch has like decided to quit.
Sorry.
We're like almost
I
there.
actually don't have a question, but I was just going to share with you, when you spoke about the patient that had an issue because she didn't want to wait all day for her medication, our medications are shipped to us as the nurses, but it's considered part of the delivery chain to the patient. So, and we don't like sitting at home either, so we actually have them delivered to the FedEx office, so then you can just pick it up from the FedEx office.
Oh.
Just a thought.
That's a thought. She did have a progression and she's no longer on therapy with us, but I think if we had a future one, I appreciate that. That's a great idea.
Hi. What is the furthest distance that you provide service for, and how do you deliver meds to those services? Is it all courier based, or do you do UPS, FedEx?
So I don't know the exact distance for oncology patients, but I do personally have one who's about 40 miles from me currently in Wisconsin. The 11 county metro is like a pretty solid space. I don't know from one side to the other or top to bottom, but it is pretty expansive. My understanding is that we, especially with these drugs, are using our courier service. So we've partnered with them and they do a lot of work for us. Yeah.
Jim's correct, we use only the courier, it's about 45 minutes, we did like a little radius.
Yeah. And-
Sorry, as pharmacists have pharmacy questions.
yeah, no, it's great.
Since you're using courier service, who picks up the bulk chemo waste?
The courier service.
Courier service.
Yep. Well, thank you so much. I think the conference is over.